What's up, engineers? In this video, we're going to be talking about congenital heart defects. This is going to be part 2. So we talked about acyanotic. In this video, we're going to be talking about cyanotic congenital heart defects. So with cyanotic, obviously these cause cyanosis. They cause a bluish discoloration of the baby. If you guys think back to acyanotic with the ASD, the VSD, the endocardial cushion defect, the PDA, all of those are primarily within that category of what we called left to right shunts. They were shunting blood from left atrium to right atrium, left ventricle, right ventricle, or they were shunting blood from the aorta into the pulmonary artery. And these conditions, the cyanotic, we can actually think about them as the opposite situation. They are called right to left shunts. So they're shunting deoxygenated blood from the right side of the heart into the left side of the heart. And when you shunt deoxygenated blood into the systemic circulation, you drop the actual systemic arterial oxygen saturation. And this can cause the bluish discoloration of the baby's skin and a lot of other nasty problems. All right, so first thing, when we talk about these, there's actually 7 different types that we're gonna go over. I know it sounds like a lot. We're gonna go through each individual one, talk about their definition. We'll go over the particular risk factors, age of presentation for some of them, the clinical picture, the diagnostic tests, and then we'll talk about the treatment, acute and surgical. First one, Tetralogy of Fallot. So for Tetralogy of Fallot, there is 4 particular findings. The first one is a VSD, a ventricular septal defect. Second one is right ventricular hypertrophy, so this thickening of the right ventricle. Third thing is pulmonary stenosis, and this is technically like the subvalvular portion, right below the actual pulmonary valve, so pulmonary stenosis. And the last one is an overriding aorta, meaning that the aorta is kind of overriding both of the left and right ventricle, right at the level of the VSD. Okay, so that is the 4 different components of Tetralogy of Fallot. Again, VSD, right ventricular hypertrophy, subvalvular pulmonary stenosis, and an overriding aorta. What are the particular risk factors, causes, things that can actually put these patients at high risk for Tetralogy of Fallot? There's a condition called Di-George syndrome. In Di-George syndrome, there's actually a deletion in the 22nd chromosome. And in this actual defect, they have an abnormal or no complete development of 3 particular structures. Their thymus, which is important for T cell development, also their parathyroids, and then lastly, the actual heart defects. And so these are the big things to remember for a patient who actually presents with these particular conditions in the clinical vignette. So Tetralogy of Fallot is associated with Di-George syndrome. Now, what is the clinical picture? What are the particular findings I need to be thinking about? Obviously, it's going to be like cyanosis. But how does this actual cyanosis present, and what's the underlying pathophysiology behind this? So, you know, in these patients who have this really, really nasty pulmonary stenosis, it makes blood very difficult to get from the right ventricle into the pulmonary artery. It's like super, super difficult because look at the narrowing of that actual pulmonary valve area. So the pulmonary valve area is super, super narrow. It is so difficult to be able to get blood from the right ventricle into the pulmonary artery. Okay, that's a problem. So what happens is, you know what actually occurs is we actually start shunting blood from the right side of the heart into the left side of the heart so that we can push this into the aorta, because we can't get blood into the pulmonary artery. And so what happens is it shunts blood over into the opposite side, from the right ventricle into the left ventricle and up into the aorta. And now in the aorta, I'm going to have a mixture of oxygenated blood from the left ventricle and deoxygenated blood from the right ventricle. That mixed blood is what causes the cyanosis. Now, the babies who actually present with cyanosis, they present in a very interesting way, and we call this TET spells. So TET spells is these patients develop this really nasty cyanosis, but it's exacerbated by very specific triggers, like whenever they're exerting themselves, they're crying, or sometimes even when they're feeding. What happens is during those time periods, it can trigger a cyanotic event. And that is important to remember, that these patients, they can actually have this bluish discoloration, this hypoxemia also effect, usually during particular triggers such as crying, exertion, or feeding. Big, big thing to remember. Okay, the other particular findings that we have to think about for these patients with Tetralogy of Fallot is very specific murmurs. When you actually look at, they have their S1, and then you're supposed to have an S2. So S1 is the closure of the tricuspid valve and mitral valve. S2 is supposed to be the closure of the aortic valve and the pulmonary valve. That's your A2 and P2. Do you guys see a P2 there? No. And so there's an absent P2. And so we only produce a single second heart sound and single S2. That's one particular finding. The second finding is, as I'm actually trying to push blood, think about this. When I'm trying to push blood into the pulmonary artery, it's not going that way. It's not going that way. If you have a very big obstruction, it's almost impossible to get blood that way. And so it shunts it over into the left ventricle. But the left ventricle is also pumping a lot of blood up into the aorta. So there is a lot of blood from both the left ventricle and the right ventricle being pumped into the aorta. And that causes this systolic ejection murmur due to a lot of blood flow moving through the aorta. So those are particular findings. So again, systolic ejection murmur at the left upper sternal border due to a lot of blood moving through the aorta. And second thing is they have a single S2 because their pulmonary valve isn't actually closing because we're not pushing any dang blood into it. So those are important things to remember. Okay, let's come down and talk about the clinical picture that are, the diagnostic testing, which are very important in this condition. All right, so another thing with tetralogy of Fallot is when we're trying to diagnose this, we can actually use a couple different tests. Chest x-ray, EKG, and echo. Echo is the gold standard. It's going to be the definitive diagnostic test. But what could the chest x-ray and the EKG potentially tell us? When you look at the chest x-ray, you have to remember this very important kind of pathognomonic term, which is it is a boot-shaped heart. Sometimes they use the term like coar in sabat. But again, a boot-shaped heart is actually one of the particular findings that you can see in tetralogy of Fallot. The next thing is if you look at the EKG, they tend to have a right axis deviation. Are these things super helpful? No, I would remember the boot-shaped heart, but what's important in the definitive diagnostic test is going to be the echo. The echo will be able to show us that they have a VSD. It'll show us the right ventricular hypertrophy. It'll show us that right ventricular outflow tract obstruction, the pulmonary stenosis. What was the other overarching theme again? An overriding aorta. And again, these are the big things to think about. So to quickly sum it, tetralogy of Fallot, RVH, pulmonary stenosis, VSD, and overriding aorta. With these, think about DiGeorge syndrome, clinical pictures. They have cyanosis, TET spells during aggravating factors. They have a systolic ejection murmur due to increased aortic flow, and a single S2 due to no blood flow through the pulmonary artery. We know the chest x-ray, boot-shaped heart, and the echo definitive diagnostic test. Last but not least is how do we manage these patients? The acute management, and this is very specific for those TET spells, the cyanotic effect from the TET spells. Whenever they're crying, they're exerting themselves, they're feeding, they develop an intense cyanosis. When that happens, what can we do to decrease the right ventricular outflow tract? So what I'm trying to do is, I want to make it to where the blood is not going from the right ventricle into the left ventricle and up to the aorta. I don't want it to go this way. I want the blood to go this way. How do I do that? First thing I can do is I can have the baby squat. And they actually learn this kind of incidentally. When they squat down, they actually squeeze their femoral arteries. And when they squeeze their femoral arteries, they increase the systemic vascular resistance of their aorta. Now the pressure in the aorta is higher. That means the afterload is higher. That means it's more difficult to push blood from the left ventricle into the aorta. And so what happens is the right ventricle says, hey man, the pressure's way too high over here. I'm not gonna push it here. I'm just gonna do my best to squeeze it through this area here. And so it reduces the mixing of the blood, which is what's responsible for the cyanosis. And so that's one particular way. The second way is we can do our best to actually try to relax this actual stenotic area. Sometimes it can spasm. And when you actually try to relax the actual infundibular portion of the pulmonary artery, and you try to relax it, you may be able to get a little bit more blood flow in that area. And that's where morphine and beta blockers have been shown to be able to relax the actual spasmed area of the pulmonary artery where it's stenotic and help to get a little bit of blood flow out. And again, if you can get blood flow into this area, you're not shunting it over into the left ventricle and the aorta. You're not mixing the blood. But ultimately, we can do these things during the TET spells. But what we need to do is surgical management. So oftentimes we'll have them squat, morphine, beta blockers, oxygen is also another thing. Give them some oxygen because that'll help. Oxygen's been shown to be able to dilate the pulmonary vessels a little bit so that you can actually get blood flow out of the right ventricle into the pulmonary artery. So don't forget that one. Oxygen as well. But surgical management is going to be the biggest thing. So sometimes what we'll do is we actually go in and dilate and stretch open that right ventricular outflow tract area. We'll close the VSD so we don't shunt blood from the right to the left. And then sometimes we'll put a palliative shunt, is we'll actually take and shunt blood from the pulmonary artery to the subclavian artery. And so that's sometimes what we'll do in these situations. All right, that covers the Tetralogy of Fallot. Let's now talk about the next one here, our transposition of the great arteries. All right, so for transposition of the great arteries, it's actually a very interesting process here. You know, normally during the actual embryonic development, the arteries, particularly the pulmonary artery and then the aorta, are supposed to kind of like spiral, okay, and then split to where you get the pulmonary artery coming out of the right ventricle and the aorta coming out of the left ventricle. In this process, they do not actually spiral. So there's a failed spiraling of the aortic area and the aorticopulmonary septum. And this actually leads to the aorta opening up into the right ventricle and the pulmonary artery opening up into the left ventricle. So this is called transposition of the great arteries, where the left ventricle empties into the pulmonary artery, the right ventricle empties into the aorta. That is a problematic issue here. What are the risk factors? What kind of conditions? Don't forget DiGeorge syndrome. Chromosome 22 deletion associated with abnormal or no development of the thymus, the parathyroid, and actual heart defects. The other thing that you have to remember is that these also have been associated with maternal diabetes. So again, don't forget transposition of the great arteries associated with maternal diabetes and DiGeorge syndrome. Now, what is the clinical picture for this one? So it's straightforward, to be honest with you, cyanosis. But why is there cyanosis? The aorta is now getting blood from the right ventricle, and it is pumping all deoxygenated blood to the systemic circulation. This is absolutely horrific. At least with Tetralogy of Fallot, there was some mixing, so you had some oxygenated and some deoxygenated. In this situation, you are literally pumping all deoxygenated blood from the right ventricle into the aorta. That is problematic, and this is relatively incompatible with life. So in these situations, it is a terrible situation where you're pumping all the deoxygenated blood into the aorta. That's the problem there. That's where you're gonna get the bluish discoloration. The other thing is whenever the oxygen levels are so low, it stimulates the chemoreceptors and your actual carotids and then the aorta, right? So the carotid bodies and the aortic bodies, they get stimulated by the low oxygen, and it triggers a reflexive tachypnea. So the babies are trying to breathe really, really fast to pull in more oxygen, hoping that it'll help actually play a role within the oxygenation process, but it's not going to. And so that's the unfortunate situation that you see here. What is the particular clinical findings that we can see when we auscultate? So when we auscultate, here we have our S1, it's the closure of the tricuspid valve and the mitral valve, and you're supposed to have an S2, the closure of the aortic valve and the pulmonary valve. Well, you're still gonna have the closure there, but guess what? In this situation, you have a very loud S2, but you only actually have the single sounding S2. You actually don't hear the splitting in this situation. There's no murmur, I think, is the big thing to remember for this one. So in the Tetralogy of Fallot, there was the systolic ejection murmur. In transposition of the great arteries, there's really no murmur, and you may just hear a loud S2. That's it. That's all I want you to remember. Okay, let's come down and now talk about the actual diagnostic findings here. So what are these diagnostic tests that we need to know? So the big thing to think about here is when, again, get that chest x-ray, EKG, echo. Which is the diagnostic test though? Echo. Echocardiogram is the best. But what could we see on the chest x-ray? What could we see in the EKG? Big thing, EKG tends to be normal. Nothing really super obvious on this one, but for the chest x-ray, you have to remember that big buzzword term. What is that buzzword term? We use the term egg on a string in this situation. So for the actual tetralogy, it was a boot-shaped heart. And the EKG wasn't a super big thing, but what I want you to know for this one is an egg on a string for the transposition of the great arteries, no special kind of EKG findings. But the echo is gonna be the super obvious thing where you'll see the aorta rising anteriorly from the right ventricle and the pulmonary artery arising posteriorly from the left ventricle. That's the big findings here. So how do we actually manage these patients? So remember I told you that there's literally all deoxygenated blood in the aorta. Everything that the right ventricle is pumping, it is literally pumping all deoxygenated blood into the systemic circulation. We gotta mix the blood. We gotta figure out a way that we can mix this blood somehow. So how do we do that? The way that we do that is we use this actual ASD here. So sometimes what we'll do is we'll actually, if a baby doesn't have an ASD in this condition, we'll literally go in and poke a hole in their intraatrial septum and make a hole, make an ASD or make it bigger. This is called a balloon atrial septostomy. And what that does is that allows blood to go from the left atrium into the right atrium. So now I can push some oxygenated blood into this actual right side of the heart. So I can get a little bit of oxygenated blood that's getting pumped out into the aorta. And that's the big thing to think about here. Sometimes what we also will have is keep the PDA open. If we keep the PDA open, we use something called prostaglandin E1 that keeps the PDA open. And what we'll do is we'll actually push blood via this actual patent ductus arteriosus into the pulmonary artery. From the pulmonary artery, it'll go to the pulmonary veins. From the pulmonary veins, guess what we have? The ASD to keep shunting all that blood into the right side of the heart. We're trying to mix the blood. So the ASD is what we really, really need, because that's going to give us some oxygenation on that right side of the heart, and we're going to push some oxygenated blood into the aorta. The PDA just keeps trying to push blood towards the left side of the heart so that we can shunt it into the right side of the heart. So these are the big things that we need. But please don't forget making the ASD via the balloon atrial septostomy. Keep the PDA open so we can shunt it into the pulmonary circulation, bring it back to the left side of the heart. But ultimately, these are not going to be helpful in the end game until we switch the arteries back to where they were supposed to go. Put the aorta coming out of the left ventricle and put the pulmonary artery coming out of the right ventricle. All right, my friends, let's move on to the next part. All right, so the next one is Truncus Arteriosus. So with Truncus Arteriosus, there is one big trunk, literally one single trunk that is emerging from both the actual right ventricle and the left ventricle. That's it. So Truncus Arteriosus is a big old trunk emerging from the right ventricle, left ventricle. Tetralogy of Fallot, right ventricular hypertrophy, pulmonary stenosis, overriding aorta, and a VSD. For the transposition, you switch them, right? Right ventricle going into the aorta, left ventricle going to the pulmonary trunk. And this Truncus Arteriosus, the right ventricle and left ventricle are all emptying into a single trunk called the Truncus Arteriosus. Sometimes we actually call this persistent Truncus Arteriosus. Now, that is a problem because this single trunk actually bifurcates into the pulmonary arteries and then into the aorta. The other kind of finding that you'll see in Truncus Arteriosus, so again, you get a single trunk emerging from right left ventricle, it bifurcates into the aorta and the pulmonary arteries, but you also normally have a VSD present there as well, okay? Now, what are the risk factors? You guys have seen this already. So Di-George syndrome. Di-George syndrome is there's a deletion of the actual 22nd chromosome causing an abnormal or no thymus, parathyroid, and particular heart defects. So you saw that with the Tetralogy of Fallot. You saw that with the transposition of the great vessels, and you're gonna see this with Truncus Arteriosus. What's the clinical picture? So we know all of them are cyanosis. What is the actual issue here? Well, actually, again, it's kind of like the Tetralogy of Fallot here, where you're pushing deoxygenated blood from the right ventricle into the Truncus Arteriosus. And you also are pushing oxygenated blood from the left ventricle into the Truncus Arteriosus. But all of this blood is actually flooding into the pulmonary circulation and flooding into the aorta. So that's the big issue here, is that you are obviously having a total mixing of blood, of deoxygenated and oxygenated blood into the Truncus Arteriosus. That's the cyanosis. That will cause the bluish discoloration. The other big thing here, which is really interesting, is you're pumping a ton of blood into this single trunk. What I say this single trunk does, bifurcates into the aorta and into the pulmonary arteries. The pulmonary arteries are getting way more blood flow than they're used to. And so these pulmonary arteries are filling the lungs, filling the pulmonary veins heavily, and they're dumping a ton of blood into the left atrium and then subsequently into the left ventricle. If you get so much blood flow coming into the left side of the heart, eventually that left heart is going to be strained, it's going to struggle, and the baby's heart will fail and they'll develop left-sided heart failure. And that is a very problematic issue here. So they have a lot of pulmonary flow because you're pushing a ton of blood into this single trunk, which bifurcates into the pulmonary artery and the aorta. They're getting a lot more flow than they're used to. This is actually one of the few that actually has a lot of pulmonary blood flow. So because of that, that can lead to left heart failure. Now, what are the particular clinical features if you're auscultating? Again, you're pushing a ton of blood through this single trunk. And so they can have a systolic ejection. Remember, that's a lot of blood flowing through this single trunk. And they also have a single S2. They don't have a pulmonary valve and an aortic valve. They got one big trunk here, which is opening up into both of these that are going to bifurcate eventually. So it's a single S2. So systolic ejection murmur, and again, a single S2. All right, what about the diagnostics? Let's come down and talk about those. All right, so the next thing here is with the chest x-ray. What do we got here? Again, think about it. We're pushing a ton of blood out of the right and left ventricle into a single trunk, which bifurcates into the pulmonary artery and the aorta. Your actual pulmonary vessels are gonna get hit with a lot of blood flow. So the pulmonary vasculature will actually be more intense. So they'll have an increased pulmonary blood flow, increased pulmonary vasculature. but also you're going to have some actual evident cardiomegaly. So these actual hearts can be a little bit bigger. Why? Because if you have a lot of pulmonary blood flow, you're pushing a lot of blood back to the left side of the heart. The left side of the heart has to accommodate all that volume, and so it actually enlarges. And so you could have cardiomegaly. The other thing with this one is that they typically have biventricular failure. Biventricular failure that you actually may see on their EKG by left ventricular hypertrophy and right ventricular hypertrophy. But again, I would focus more on the increased pulmonary blood flow and cardiomegaly. What's the definitive diagnostic test, my friends? Echocardiogram, which is going to show me a single trunk arising from the left ventricle and the right ventricle. How do I manage these patients? So, surgical management is absolutely required within the first couple weeks of life. Now, it's a minimal cyanosis because you do have some mixing. It's not complete cyanosis where there's only deoxygenated blood that you saw in like a Truncus Arteriosus, in a transposition of the great arteries. In this one, you have a little bit of mixing. So what we can actually do as in the interim until we get this surgical management is we can do some particular medical therapies. And what those are is, because you're overloading the left ventricle with a lot of blood flow from the pulmonary circulation, you can actually try your best to reduce a lot of the actual pulmonary edema and a lot of the actual congestion in the lungs by giving these babies positive pressure ventilation to push some of the fluid out of the lung areas. Also diuretics to remove some of the pulmonary edema. And you can give them inotropes to squeeze blood out of the heart, and give them drugs that actually relax the aorta and are actually some of the distal vessels. And so that reduces the afterload and ensures that we push a lot of blood out into this single trunk. So again, one of the big things to do here is to try to give positive pressure ventilation and diuretics to pull off a lot of the pulmonary edema from the increased pulmonary flow, and give them afterload reducers and inotropic agents to ensure a lot of blood is getting pumped out of the heart. Those are the big things to think about here. Let's move on to the next one, which is total anomalous pulmonary venous return. Let's talk about the next one, total anomalous pulmonary venous return. In this condition, it's where the pulmonary veins, normally the pulmonary veins are supposed to empty into the left atrium, but they don't. In this situation, the pulmonary veins empty into the right atrium via these things called connecting veins. And that's what's really important. So it's hard to see in this diagram. So what I'm going to do is imagine I'm looking behind the heart. So here's another diagram I think gives it a little bit better view. So here's our pulmonary veins. So this would be the actual right pulmonary veins. So the right pulmonary veins here. And these would be your left pulmonary veins. They both come together and then empty into the left atrium. In normal patients. In these patients, they do not. And instead, they have these little structures. So there can be different types. You can have what's called a supracardiac total anomalous pulmonary venous return, or a cardiac total anomalous pulmonary venous return, or an infracardiac. I'm not going to show the infracardiac here just because it can become a little bit confusing. I want to get the basic concept across, and I think the cardiac and supracardiac give you that. So with the supracardiac, so you have what's called the superior vena cava, and that empties into the right atrium. What can happen is, here's your pulmonary veins. They're supposed to empty into the left atrium, but they don't. There's a connecting vein that connects the pulmonary veins into the superior vena cava. So all the blood that's coming through here, instead of it emptying into the left atrium, which it should, guess where it goes, my friends? Right via this connecting vein into the superior vena cava and into the right atrium. So all the oxygenated blood that you're supposed to be carrying via the pulmonary veins to the left atrium is going right to this connecting vein, right to the right atrium. So the right atrium is getting all the oxygenated blood that's supposed to go to the left atrium. Another way that you can have that would be a supracardiac one, where it connects to the superior vena cava. What if it connects right to the heart, the right atrium? Sometimes you can have these connecting veins which empty blood directly into the right atrium, and that is the cardiac type of total anomalous pulmonary venous return. But either way, in both of these situations, the pulmonary veins, which are carrying oxygenated blood supposed to go to the left atrium, it's going right into the right side of the heart. Whether it be superior vena cava via a connecting vein, or whether it be right into the right atrium via a connecting vein, this is emptying oxygenated blood into the right side of the heart, which is supposed to be primarily deoxygenated. That is a nasty situation to have. Okay, what can this look like? What's the clinical picture here? The big thing here is that you have all the blood that's inside of the right side of the heart, all the blood on the right ventricle is all having oxygenated and deoxygenated. You are literally getting no oxygenated blood flow coming into the left atrium. Nothing. No oxygenated blood flow is coming into the left atrium. That is absolutely disastrous. All the oxygenated blood is going into the right ventricle, and all of this is getting pumped into the pulmonary arteries, going to the lungs to be able to get more oxygenated, and then they're supposed to come back via the pulmonary veins and empty into the left atrium, but they're not. This condition is absolutely terrible, and the patient will die because you're literally pushing no blood via the aorta into the systemic circulation. So in these situations, these patients have no oxygenated blood getting into the left atrium. Super disastrous. And again, because you're pumping tons of blood via the pulmonary arteries and then back into the pulmonary veins, as they try to empty into the right atrium, they kind of develop a pulmonary vein obstruction, if you will. So imagine all this blood as trying to be able to get to the actual right atrium. It kind of just like accumulates and backs up and backs up and backs up into the pulmonary vessels. It can increase the pulmonary pressures. And so what happens is that fluid backs up into the pulmonary veins. It can cause a lot of pulmonary edema. And so it can cause respiratory distress. They can actually start breathing really, really quickly. They can have tachypnea. They can have dyspnea. So these are the big findings. So again, to summate, they'll have cyanosis because all of the oxygenated blood that's supposed to be going from the pulmonary veins into the left atrium is not. It's all dumping into the right atrium. No oxygenated blood is going into the left atrium, left ventricle, and into the aorta. No oxygenated blood going to the systemic circulation. That's absolutely terrible. The other thing is respiratory distress. Because you're having all of this blood that's in the pulmonary veins kind of like stasis, it's having difficult time going via this connecting vein. What happens is it backs up into the lungs, causes pulmonary edema, respiratory distress such as dyspnea, tachypnea, hypoxemia. Big things to remember here. What if you take the actual stethoscope, put it to the chest, what would you hear? So again, you have a S1. This is, again, what is this? This is the closure of the tricuspid and the mitral valve. Then you have the S2, which has the aortic component and the pulmonary component. Because a huge amount of blood flow is going to the right side of the heart, because you're actually having the pulmonary veins empty into the right side of the heart, a ton of blood is being pushed into the pulmonary circulation. A lot of blood is moving into the pulmonary artery. That's going to cause a systolic ejection murmur, particularly going through the pulmonary artery. The other thing is you'll have a split S2 because it's going to take a longer time for the actual right ventricle to contract and eject blood out of the right side of the heart into the pulmonary artery, and a longer time for the pulmonary valve to close. And so the pulmonary valve sound will come later, and this causes a splitting of the S2. Last but not least, because you have a lot of blood that's shunting and going into the right atrium, all that blood is moving from the right atrium into the right ventricle. Across what structure? The tricuspid valve. If a lot of blood flow is moving across the tricuspid valve, it causes a diastolic rumble. And so these are the things that you can see in a patient with total anomalous pulmonary venous return. Let's talk about the diagnostic findings. All right, so let's move into the diagnostic tests here. So again, think about these: chest x-ray, EKG, echo. Obviously, echo is the definitive test, but if you get a chest x-ray, what are the particular findings here? So again, you're gonna have what's called increased pulmonary blood flow, increased pulmonary vasculature, because again, you're pumping a lot of the blood into the right side of the heart, pumping a lot of blood into the pulmonary vessels. So the pulmonary vasculature will be more intense. The other thing is you have something called a snowman sign. That's the pathophysiologic finding. So for Tetralogy of Fallot, it was the boot-shaped. For transposition, it was egg on a string. And then for this total anomalous pulmonary venous return, it is the snowman sign. The other thing is you're actually overloading the right side of the heart, causing it to have to deal with more volume, more pressure. It's going to thicken. It's going to get hypertrophied. And so you can develop right ventricular hypertrophy. And because more blood is going into the right atrium, it will enlarge. So you will have right atrial enlargement. These are actually a little bit more important findings I would remember as well. So remember the snowman sign, right atrial enlargement, right ventricular hypertrophy on the EKG. But the best test is echo. And the echo will show a big right atrium. It'll show the connecting veins and a obstructed pulmonary veins. How do we treat this? We have to surgically resect it and actually reconnect these different structures from the pulmonary veins to the left atrium. If we don't, these babies will die. It is emergent, has to happen right after birth. All right, let's move on to tricuspid atresia. All right, so the next one here is called tricuspid atresia. So atresia is basically, having an abnormal or not completely developed or even an absent tricuspid valve. And so that's kind of the basic concept here: is an absent or abnormally maldeveloped tricuspid valve, a hypoplastic right ventricle. The other thing is you can have a VSD and lastly, an ASD. So those are the big findings for, again, tricuspid atresia. ASD, VSD, hypoplastic right ventricle, and an absent tricuspid or maldeveloped tricuspid valve. Big thing is the age of presentation. Please don't forget this. It is a prenatal diagnosis. So oftentimes, whenever a baby is born, it's usually going to be super evident whenever they have this severe cyanosis, okay? So again, prenatal diagnosis, and again, diagnosis of, very importantly, newborns. So, clinical picture, how do these babies with tricuspid atresia present? Again, cyanosis, all of them present with cyanosis, but what's the reason for the cyanosis? So the reason for the cyanosis here is, again, you're getting literally no blood getting from the right atrium to the right ventricle, okay? That is a problem. No blood is getting from the right atrium to the right ventricle. Therefore, no blood from the right ventricle can get into the pulmonary artery. That is disastrous. So, if these patients do not have an ASD, they will die very quickly. So hopefully they have an ASD, and if they don't, I'll talk about later, we have to make one. But let's say that they have an ASD, because most of them do. What will happen is blood will shunt from the right atrium to the left atrium, and then down into the left ventricle. Okay, so there's our shunt. We can't get blood from the right atrium to the right ventricle because of the atretic tricuspid valve. If you have an ASD, blood can go from the right atrium into the left atrium. Now, from the left atrium, we'll go down into the left ventricle, and from the left ventricle, we'll pump blood into the aorta, but we need some blood to be able to go into this actual pulmonary trunk. So some of the blood will shunt over into the actual pulmonary trunk. But again, as you see here, where's the mixing process taking place? The mixing process, we're pushing deoxygenated blood from the right atrium to the left atrium, from the left atrium into the left ventricle, and we're pushing into the aorta a mixture of blood, okay? The deoxygenated blood coming from the right atrium to the left atrium, and the oxygenated blood that's in the left side of the heart, okay? Now, you need the dang VSD, hopefully, to be able to pump blood from the left ventricle into the pulmonary trunk, and then from the pulmonary trunk into the actual pulmonary arteries. That is the big thing here, okay? Because we need some pulmonary blood flow so that we can oxygenate the blood and send the blood back to the left side of the heart, oxygenated. If we can't do that, we can't oxygenate the blood, and that's another problem that we'll run into. So again, why is the cyanosis present? Because right atrium can't empty blood into the right ventricle. If they did not have an ASD, they will die. If they do have an ASD, they'll pump the blood from the right atrium to the left atrium. That's pushing deoxygenated blood into the oxygenated chambers of the heart and pushing that out into the systemic circulation. If we need to get some kind of pulmonary blood flow occurring, we need the VSD for the blood from the left ventricle to pump across the VSD into the right side of the heart and into the pulmonary arteries. Boom. What are the particular auscultatory findings that we can have in these patients? Well, they have a big old fat VSD. So guess what that's going to do? Give me a holosystolic murmur at the left lower sternal border. That's due to the VSD. And they'll have a single S2. But again, don't forget the holosystolic murmur due to the VSD in these patients with tricuspid atresia. Okay, that's the basics there. Let's talk about the diagnostics. All right, so the next thing is the diagnosis. Chest x-ray, EKG, and echo. We need these to diagnose it, right? But what's the best one? Echo. That is your definitive diagnostic test. Now, if you had the chest x-ray, what would that show? Well, again, we're obviously telling that we're not getting a lot of blood flow through the pulmonary vessels because we aren't able to get blood flow from the right atrium to the right ventricle, from the right ventricle into the pulmonary artery because of the atretic tricuspid valve. So, if you have the ASD, you can pump the blood from the right atrium to the left atrium down to the left ventricle, and then some of the blood, if they have a VSD, can pump over into the pulmonary artery. But either way, you're not getting a lot of blood flow through the pulmonary vasculature. So in this situation, if you look at their pulmonary vasculature, it's going to be really, really reduced. They'll have a decreased pulmonary vasculature, pulmonary blood flow. If you look at their EKG, might be somewhat helpful, not super helpful I consider, but again, you may see some left axis deviation, some right atrial enlargement. Again, those are non-specific findings. What do you need? You need the echo. The echo can show you the VSD. It can show you the ASD. It can show you the hypoplastic right ventricle. And on top of that, it'll show you the atretic tricuspid valve. Those are the big things that you absolutely need to make the diagnosis. How do we actually manage these patients? Remember what I told you. If they don't have an ASD, they will die because they have no way to mix the blood and get some kind of blood flow again, to the actual pulmonary circulation. So in this situation, what do we have to do? If they don't have one, we will make one. And if it's a small one, we'll make it bigger. But we gotta make an ASD. And that ASD allows for blood to go from the right atrium into the left atrium so we get some kind of blood flow trying to get through the pulmonary circulation. Because if we don't get any blood flow through the pulmonary circulation, we can't oxygenate the blood and it's not going to matter what we do. So we have to be able to do that. So we make an ASD. How do we make the ASD or make it bigger? A balloon atrial septostomy. Again, what does it do? It allows for us to shunt blood from the right atrium to the left atrium because we can't get it down into the right ventricle. So we need a way to be able to get it down into the right ventricle and up the pulmonary artery. So we use the ASD. And then from there, we use that VSD to pump it up through the pulmonary arteries. Okay? The other thing is if you have a PDA, this is also huge. Again, we're trying to get some kind of pulmonary flow here. If we don't get any pulmonary flow, we can't oxygenate the blood and bring that oxygenated blood to the left side of the heart. That's going to be a problem. So what we do is if they have the PDA open, we'll keep it open because what that'll do is that'll take any of the actual blood and push it into the aorta so that we can get blood flow through the pulmonary vessels. Oxygenate that blood and then send it back to the left side of the heart so we can pump that out to the systemic circulation. So also keep that PDA open so that you can continue to shunt blood into the pulmonary artery to maintain good pulmonary blood flow so that you can oxygenate it and bring it to the left side of the heart. So we keep the PDA open how? We give them prostaglandin E1, the prostaglandin infusion to keep that open. And also for cardiorespiratory support, give them as much oxygen as possible and give them inotropes to squeeze blood out of the left side of the heart, okay? So that's your cardiorespiratory support. Surgical management is these need to be surgically treated as soon as possible. It's required. And so sometimes we call that a surgical Fontan procedure that is required in these situations. Okay, we talked about tricuspid atresia. Let's move on to Ebstein Anomaly. All right, so let's now talk about Ebstein Anomaly. Like, whoa! That is the biggest heart I ever done seen. So this is Ebstein Anomaly. In this condition, they got a gargantuous, a huge right atrium. So it's a super big right atrium. They also have an ASD, and we'll talk about why, and thank goodness they have this dang thing. And then they also have some abnormal tricuspid valve. They got some low-hanging tricuspid valves. So they're super inferiorly displaced. So that is the big thing with Ebstein Anomaly. Huge right atrium, inferiorly displaced tricuspid valve, and again, an ASD. What are the risk factors? You guys can't forget this. Maternal lithium use. Again, we talked about for Tetralogy of Fallot, for Transposition, for Truncus Arteriosus, it was the Di-George syndrome, right? That was the big overarching theme for all of them. But again, for this one here, for Ebstein, it is maternal lithium use. Please don't forget that. And their presentation tends to be actually a little bit later, adolescence, sometimes even into adulthood. Okay, how do they clinically present? It's so redundant, but it's cyanosis. They present with a bluish discoloration. Why? Here's why. Because of these inferiorly displaced tricuspid valves, it actually kind of like blocks blood flow. It really makes it difficult to get blood into the pulmonary artery. Okay? It kind of like, in a way, blocks off blood flow to the pulmonary artery because of these low, inferiorly hanging tricuspid valves. But also, these tricuspid valves are super low hanging and super displaced far away from one another that it's super easy to pump blood from the right ventricle back into the right atrium. So again, remember, these tricuspid valves, they hang low and block or obstruct blood flow into the pulmonary artery. So you can't get blood into the pulmonary artery. Instead, they hang low, displace far enough that blood can shoot back into the right atrium. Then, when it shoots back into the right atrium, they have this ASD, and that starts shunting blood from the right atrium into the left atrium. Then, from the left atrium, it'll go down into the left ventricle. And then from the left ventricle, we'll pump that out into the systemic circulation. So when we have the left ventricle and we pump that out into the systemic circulation, what kind of blood are we pumping out into the aorta? A mixture of oxygenated and deoxygenated blood. So that is why you have the cyanosis, the mixing of the blood. The other thing is, think about this. As you pump a lot of blood back into the right atrium, a lot of blood over to the left atrium, a lot of blood down to the left ventricle, you're overloading the left side of the heart. The left atrial pressures get super high, the left ventricle gets overloaded, and so you can have left heart failure, which could present with pulmonary edema. Okay. The other thing is, if we take the stethoscope, put it on the chest, what could we potentially hear? You may hear a holosystolic murmur at like that left lower sternal border, but this is not due to a VSD. This is due to the tricuspid regurgitation because of these inferiorly displaced and furtherly displaced away from one another tricuspid valve leaflets. The other thing that you want to remember here that's super different and just the only one that's super random out of all of these is that sometimes you can have a gallop, an S3, like a quadruple. So you have an S1, closure of tricuspid and mitral, S2, closure of aortic and then pulmonary. An S3 heart sound is due to a lot of blood flow moving into the ventricles during diastole, and this is a rapid ventricular filling. That's an S3 heart sound, and an S4 heart sound, which is where there is actually an atrial contraction, and so the atria are actually contracting to push a ton of blood down into the left ventricle. So they can have kind of a summation gallop, an S1, S2, S3, and maybe even an S4. Okay, let's talk about the diagnostic tests. So we get the chest x-ray. What do we need to know about this one? So again, think about it, guys, okay? You're getting not very much blood going into the pulmonary artery. So your pulmonary vasculature going to be filled or underfilled? They're going to be underfilled. There's going to be a decreased pulmonary vasculature because, again, you're having the inferiorly displaced tricuspid valves kind of obstruct or block off the pulmonary outflow tract. You can't get blood out. It's going to decrease the actual pulmonary blood flow. And if you look, the right atrial border on the heart shadow is going to be gargantuous. That's one big thing. EKG, this is the one that's like, I think actually out of all the EKG stuff, maybe worth actually remembering. And that is that you can see this in Wolff-Parkinson's White syndrome type B. So in this condition, there may be an abnormality where they have an accessory bundle between the right atrium and the right ventricle, which allows for the electrical potentials to move down into the right side of the heart. Okay, and so again, Wolff-Parkinson's White syndrome type B may be a particular EKG finding that differentiates this from all the other ones. Okay, but echo is going to be the definitive diagnostic test. You'll see a big atrium, right atrium. You'll see an ASD, and you'll see the low-hanging inferiorly displaced tricuspid valve. Okay, how do we manage these? Okay, think about this one. Because we're getting very little pulmonary blood flow, okay, we're getting very little pulmonary blood flow because of the inferiorly displaced tricuspid valves. We have to get some kind of pulmonary blood flow going to the pulmonary arteries so that we can at least oxygenate the blood and send that oxygenated blood to the left atrium. Because if we can't oxygenate it, oh boy, things are going to get very, very bad. So what we want to do is if we have a PDA, we want to keep that dang thing open, because what the PDA is going to do is all that blood, remember we have the ASD here. Remember, we're going to pump blood from the right ventricle to the right atrium, from the right atrium into the left atrium, and you're going to fill the left atrium and then subsequently the left ventricle, pump a lot of blood into the aorta. But if you notice, this inferiorly displaced tricuspid valve really makes it hard to get any blood into the actual pulmonary artery. So you're going to get very little pulmonary blood flow. But we want to try to be able to maintain a decent pulmonary blood flow so we can oxygenate the blood. If you keep a PDA open, it'll shunt blood into this actual pulmonary artery. So you get more pulmonary blood flow, oxygenate that blood, and send that oxygenated blood back to the left side of the heart. Okay? So we keep the PDA open in this situation. We use a drug called prostaglandin E1. The other thing is, if we can try to do our best, because the pulmonary the left atrial pressures are going to be super high because we're pushing all the blood from the right atrium to the left atrium is going to get overfilled. If it gets overfilled, it's going to start dilating, and the pressure inside of the left atrium kind of rises, so it kind of backs up into the pulmonary circulation, and that can kind of up your pulmonary vascular resistance. Sometimes we can give certain types of pulmonary vasodilators to actually relax those vessels a little bit, making it a little bit easier to pump blood flow into the pulmonary artery. And so we can give things like inhaled pulmonary vasodilators like nitric oxide or a drug called milrinone. The last case here is the surgical management. This is absolutely necessary in severe cases. You may need to perform palliative surgery on these patients. So again, big things to think about for this one is Ebstein anomalies. Please don't forget that maternal lithium use. Again, you can see the cyanosis, the heart failure. Remember the holosystolic from tricuspid regurg, the summation gallop, decreased pulmonary blood flow, Wolff-Parkinson's-White syndrome type B. Echo is the definitive diagnostic test. Keep the PDA open and try to reduce the pulmonary vascular resistance so you can try to get some of the blood from the right ventricle into the pulmonary artery, but ultimately you need surgery. Let's finish this up with hypoplastic left heart syndrome. All right, so this last one here is hypoplastic left heart syndrome. So this is basically defined as a patient having a hypoplastic, so very, very malformed, very maldeveloped left ventricle, and even like the left ventricular outflow tract going into the aorta. And also, they can have some abnormalities of their mitral valve. See how we're missing one of the actual mitral valve leaflets? And aortic valve abnormalities. See how we're missing one of the aortic valve leaflets as well? So because of that, that's the big thing to remember. Hypoplastic left ventricle and the left ventricular outflow tract and some abnormalities of their mitral and aortic valve. Now, big thing, see this cute little baby? The age of presentation is typically delayed a little bit, sometimes up to about a few weeks after birth. When the ductus arteriosus closes, this can become a problematic issue when you can see this. Okay, so clinical picture. So we know it's a hypoplastic left ventricle, its outflow tract, and abnormalities of the aortic valve, mitral valve. Clinical presentation sometimes a few weeks after the ductus arteriosus closes. What's the clinical picture? We know it, cyanosis. Why is there cyanosis? Okay, so the left ventricle, let's just put it like this, it sucks. It's not very good at doing its job. So because of that, it's not getting blood out into the actual systemic circulation very well. What happens is, because we can't get blood out of the left ventricle and into the aorta very well, because of the very weak, decreased functioning left ventricle or the decreased functioning left ventricular outflow tract, blood will actually back up into the left atrium. The left atrium will then do this. It'll pump this blood from the left atrium over into the right atrium via an ASD. Then from the right atrium, it'll go down to the right ventricle. From the right ventricle, you'll pump this structure here into the pulmonary artery. And then from the pulmonary artery, you know you have this structure here called the PDA. You'll pump this blood here from the actual pulmonary artery into the PDA. So what happens is you get a mixing of blood. Let's see if we can make sense of this again. Left ventricle sucks, can't pump blood out into the aorta. That is a problem because if the left ventricle can't pump blood out into the aorta, we get no systemic arterial blood flow and the baby will go into cardiogenic shock, and it can happen. We'll talk about that in just a second. So how do we compensate for this to be able to get some blood into the aorta? The blood will move via the ASD from the left atrium into the right atrium. So now you have oxygenated and deoxygenated blood in the right atrium and right ventricle. The right ventricle will pump that mixture of oxygenated and deoxygenated blood into the pulmonary artery. If their PDA is open, they will pump a mixture of deoxygenated and oxygenated blood into the aorta. That's where you get the mixing of blood. That's where you get the actual bluish discoloration, okay? That's one particular finding here. The second finding is the cardiogenic shock. So the left ventricle sucks. It can't pump blood. It's hypoplastic and it's not very good at being able to contract and get blood out of the left ventricle. So because of that, the left ventricular cardiac output, the amount of blood that you can pump out of the heart within 1 minute, drops significantly because of its decreased function. If we have less blood flow moving through the actual left ventricle into the aorta, less cardiac output, that drops the blood pressure, causing hypotension and putting a baby at risk of cardiogenic shock. So this is a very scary condition for these babies. So again, they develop cyanosis because they can't get blood out of their left ventricle. So they use an ASD to pump oxygenated blood via the left atrium into the right atrium through an ASD, from the right atrium to the right ventricle, from the right ventricle to the pulmonary artery. If the PDA is open, it'll pump that blood from the actual pulmonary artery into the aorta, pushing a mixture of blood, deoxygenated and oxygenated blood into the aorta. That's where you get the cyanosis. Because the left ventricle sucks, it can't pump blood out of the heart, cardiac output drops, hypotension ensues, and cardiogenic shock will develop very quickly and the baby can die. So, what are the particular clinical features that if you take your stethoscope, put it to the chest, what would you hear? There's really no specific murmur, and you may only hear a single S2 because no blood is getting out through the aorta very well, and so it doesn't really cause a true, complete aortic closure sound. So the A2 component of S2, you don't really hear that. All they really have is the pulmonary component. So that's why you get the single S2. What are the actual diagnostic tests that I need to know? Let's come down and talk about that. All right, so we need the diagnostic tests. What are they? Chest x-ray, EKG, echo. All right, so chest x-ray, think about this, guys. Our left ventricle sucks, we're not pumping blood out into the aorta. We're shunting it over into the right side of the heart via the ASD. So we're pushing a lot of blood into the pulmonary artery. So if you look at the pulmonary blood flow on their chest x-ray, it'll be increased. They'll have an increase in their pulmonary vasculature. Well, that makes sense. EKG, again, you can do without it, but again, if you really wanted to know, you could see what's a potential right axis deviation, and that's because you're pushing a lot of blood into the right side of the heart, so it could hypertrophy. You may have a little bit of enlargement of the right atrium, and then again, a right axis deviation may be particularly present. But echo is the gold standard. It's going to show the hypoplastic left ventricle. It's going to show the hypoplastic left ventricular outflow tract. And it's going to show, again, a mitral valve and aortic valve abnormality and potentially even an ASD. What do we do to keep these patients alive long enough so that we can surgically treat this if possible? So again, that PDA, it's necessary, guys. If we don't have that PDA, we can't do what? Again, think about it. Here's your ASD. We have our left ventricle's not doing good. Can't get blood out. Uses the ASD to pump it over into the right atrium, right ventricle, pulmonary blood flow. We're getting like very little blood into the aorta. I need blood in my aorta to deliver oxygen, at least some type of blood flow to the tissues. Use the PDA to shunt some kind of blood into the aorta so that it can actually deliver some kind of volume of blood so that the baby doesn't die from cardiogenic shock. Even though it's mixed blood and there's less oxygenated blood, there's at least some blood flow. That's important. We need to keep the PDA open. What do you use to do that? The prostaglandin E1. But surgically is the most important thing. Sometimes it's a palliative surgery. And sometimes that doesn't even work, unfortunately, and the baby will actually need a heart transplant. But that covers hypoplastic left heart syndrome and covers all of the actual cyanotic congenital heart diseases. And engineers, I hope this made sense. I hope that you guys enjoyed it, and as always, until next time.